Venous drainage system of the lower extremity, it consists of mainly three sets of veins. Okay. Silence. So it consists of mainly three sets of veins: deep veins, superficial veins, and the perforating veins. And all these veins, they contain delicate one-way valves, and that normally open to allow the blood to flow towards the heart. And they prevent the blood from flowing in a retrograde fashion after the valves close. Okay. And if this retrograde flow occurs, there will be disease condition called varicose vein. Okay, next. Okay, so these are the veins included within these three groups. First is the superficial veins. Superficial veins contains two veins mainly: long or great saphenous vein and short saphenous vein. See here, this bluish one, light blue colored, this deep blue colored one is the great saphenous vein, and here from here up to the knee, the deep blue one is the small saphenous vein, and light blue one, this one is the deep vein, part of the deep vein. In the thigh it is femoral vein, in the popliteal region it is popliteal vein, here in the leg it is the tibial vein. These are the deep veins. Okay. And this femoral vein is continues as the iliac vein above. So deep veins include the anterior and posterior tibial veins, peroneal vein, popliteal vein, and femoral vein. So these are included within deep veins. And also there are perforator veins. Perforator veins pierce the deep fossa of the lower limb, and it connects the superficial vein with the deep vein. Okay. And it also contains the valve which help in flow of blood from superficial to deep vein, not in the opposite direction. Okay. And if there is incompetency of these valves in the perforator veins, there will be retrograde flow and the superficial veins will be dilated. Okay. So today we will discuss this superficial veins only. Superficial veins in details. This comes as a short note. This great saphenous vein and short saphenous vein. Okay. Okay. Next. So great saphenous vein or long saphenous vein, it is the largest and longest superficial vein of the limb. Okay. In our body, it is the largest and longest vein in our body. And it begins on the dorsum of the foot from the medial end of the dorsal venous arch. Here, one arch is formed on the dorsal aspect of the foot. From the medial end of this arch, this great saphenous vein is starting. Okay. And it runs about 1 to 1.5 inch anterior to the medial malleolus. This relation is important. It always lies anterior to the medial malleolus and along the medial side of the leg and behind the knee. This is the location of this vein. Okay, next. Now, at the ankle, the position of great saphenous vein is constant, lying in the groove between the anterior border of the medial malleolus and the tendon of tibialis anterior. Medial malleolus is part of the tibia. Okay. So it lies in between the anterior border of the medial malleolus and the tendon of tibialis anterior. It is a muscle of anterior compartment of the leg. Next. Okay. Now in the thigh, it inclines forward to reach the saphenous opening. After passing on the posterior aspect of the knee, it enters into the thigh. This is the thigh region, and it inclines forward to reach the saphenous opening. Here is the saphenous opening in the deep fossa. And this opening is covered by fossa that is known as cribriform fossa. There are small openings in this fossa. That's why the name has been given cribriform. So saphenous opening where it pierces the cribriform fossa and opens into the femoral vein 3 to 4 cm below and lateral to the pubic tubercle. Here in this region is the pubic tubercle. So it is about 3 to 4 cm below and 3 to 4 cm lateral to the pubic tubercle. Okay, so here it opens into the femoral vein. Okay, next. In the lower two-third of the leg and in the upper two-third of the thigh, the vein lies on the deep fossa, and where the vein crosses the knee joint, it becomes more superficial and often subcuticular. Okay, so these are relations with the deep fossa. Next. Now the structures accompanying this great saphenous vein. Okay. These structures are important because these structures become injured during stripping of the vein. Stripping of the vein is done in case of varicose vein. Stripping means removal of whole of the vein. Okay, which part is varicose? Okay, varicose means veins, blood is pooling in the vein. Veins become tortuous and dilated. Okay, so in the leg, the saphenous nerve lies in close relation with the great saphenous vein, and the nerve is very closely applied to the vein in the lower two-third of the leg and often injured in exploring or stripping the saphenous vein. Now, in the thigh, the medial femoral cutaneous nerve runs in close relation with the vein. Another nerve which lies in close relation in the thigh. In the leg there is saphenous nerve and in the thigh there is medial femoral cutaneous nerve. So these two important nerves are lying in relation with this vein. Next. Now throughout its length the great saphenous vein is accompanied by lymphatic trunks draining the dorsum of the foot and anterior and medial aspects of the legs and the thigh. And this lymphatic drain in superficial inguinal lymph node. Okay, another structure which is accompanying the great saphenous vein. Next, now the tributaries of the great saphenous vein. Tributaries you have to remember. Okay, it is also asked in Viva. Important for your OSPE. In OSPE, you can be given great saphenous vein to identify, and related questions will be asked. Okay. So just below the knee, great saphenous vein receives the posterior arch vein, also known as Leonardo's vein, and which collects the blood from the posterior medial aspect of the calf. And anterior veins of leg, these are also known as Stocking's vein. Okay, ascend across the seam and join either the great saphenous vein or posterior arch vein. Next is there is free anastomosis between the tributaries of the short saphenous vein and venous arch connecting the medial ankle perforating veins, and these medial ankle perforating veins are connected with the great saphenous vein in the lower third of the leg. You will see this vein in the diagram. So main two tributaries here we are getting is the posterior arch vein and anterior veins of the leg, and short saphenous vein is also a tributary of this great saphenous vein. Next. So those veins who are draining into the great saphenous vein in the leg and near the knee joint. Now the tributaries in the thigh, before entering into the saphenous opening via the cribriform fossa, it receives these tributaries: anterolateral vein, posteromedial vein of the thigh, and these three are the superficial veins: superficial external pudendal vein, superficial epigastric vein, superficial circumflex iliac vein. These three veins accompany the superficial branch of the femoral artery in the thigh, and there is deep external pudendal vein. The femoral artery has branches named are same as these veins, and these veins are accompanying the branches of the femoral artery. So all these are tributary of the great saphenous vein in the thigh. Now, in the lower third of the thigh, long saphenous vein connect with the femoral vein in the Hunter's canal by long perforating vein. This is one important perforator vein that is known as Hunterian perforator. Okay. This was named against one name of one scientist. Next, see here. This is the course of the great saphenous vein. Okay. Here, this is dorsal venous arch. From here, from the medial end of this dorsal venous arch, this vein is starting. This is the beginning of the great saphenous vein. Now it is receiving its tributaries. This is posterior arch vein. Here is the anterior saphenous vein. Okay, these are draining into this great saphenous vein in the leg, and these are smaller tributaries draining the area of the heel. Then it is continuing in the thigh, and these are the perforator veins, ankle perforators, 3 perforators of the ankle region, also known as Cloquet's perforating vein, also draining. It is connected with these perforators. Now in the thigh, here you can see this Hunterian perforator is connected to this vein, and these are the tributaries: anterolateral vein, posteromedial vein. These are the 3 veins: superficial circumflex iliac coming from the anterior superior iliac spine. Then here is the superficial epigastric vein, and here is the superficial external pudendal vein. And this is the saphenofemoral junction. This thick vein containing valves. See, this thicker vein is the femoral vein. So this great saphenous vein is passing through the cribriform fossa at the saphenofemoral junction and draining into the femoral vein here in the thigh, upper part of the thigh. Okay. So this is the course of the great saphenous vein. Okay, next. See here, this is schematic diagram. Here is the dorsal venous arch. Here it is forming great saphenous vein. This is anterior leg vein, posterior arch vein draining into the great saphenous vein in the leg. These are the ankle perforators, medial ankle perforators, upper, middle and lower perforator. And here is near the re another perforator is present. This is the adductor canal perforator or Hunterian perforator, and these veins are draining just before entering into the saphenous opening. This is the opening in the deep fossa of the thigh. Deep fossa is known as fossa lata of the thigh. So here is the anterolateral vein, posteromedial vein, and these are the 3 veins: superficial circumflex iliac, superficial epigastric and superficial external pudendal, just before entering into this saphenous opening of the deep fossa. Okay, and finally it is draining into this femoral vein. Okay, so you practice a schematic diagram like this. Okay, next. So summarization. So great saphenous vein lies in the superficial vein and easily seen. Great saphenous, it is a Greek word that means it can be easily seen. Great means it is the longest vein, and saphenous word comes from a Greek word, and that means can be easily seen. And the great saphenous vein is the longest vein of our body and represents the preaxial vein of the lower limb. It is also called the long saphenous vein. Next. This is the course of the vein. So it is formed on the dorsum of the foot by the union of medial end of the dorsal venous arch of the foot and the medial marginal vein of the foot. And the vein runs upward about 2.5 cm in front of the medial malleolus, crosses obliquely the medial surface of the lower third of the tibia and then ascends a little behind the medial border of the tibia to reach the knee, where it lies on the posterior medial aspect of the knee joint, about 1 hand's length posterior to the patella. And from here it runs upward along the medial side of the thigh to reach the saphenous opening, also known as fossa ovalis, but this term is more frequently used, saphenous opening. Okay, and it passes through the saphenous opening after piercing the cribriform fossa. Cribriform, the word means sieve-like. Okay, multiple openings are there, very small openings, and drains into the femoral vein after piercing the femoral sieve. Okay, next. So these are the tributaries. At the commencement, medial marginal vein here near the commencement. In the leg, there is communicating veins between small saphenous vein and deep vein and posterior arch vein. Okay. Now, just below the knee, anterior veins of the leg, they extend diagonally upward, forward and medially. Here is the anterior leg vein, here is the posterior arch vein. Anterior leg veins, they extend diagonally upward, forward and medially across the seam, join the great saphenous vein and a few veins from the calf which communicates with the small saphenous vein. Now in the thigh, anterolateral vein, posterior medial vein is also known as accessory saphenous vein. Okay, it lying parallel to this great saphenous vein. That's why named as accessory saphenous vein. And just before piercing the cribriform fossa, these three veins: superficial epigastric, superficial circumflex ilia, and superficial external pudendal. Okay, so these tributaries you have to remember. Tributaries are very frequently asked in your viva, also important for theory. Okay, next. So there are valves are present in the great saphenous vein. There are about 10 to 20 valves in the great saphenous vein, out of which the location of two valves needs special mention. Okay, one which lies just before it pierces the cribriform fossa, and the other one which lies at its junction with the femoral vein, that is saphenofemoral valve. Okay, and the saphenofemoral valve is a great functional significance because absence of this valve become the victim of high venous pressure and develop the varicose vein, which commences at the saphenofemoral junction and gradually extends downward. Okay, that's why this saphenofemoral valve is very important. If incompetency occurs in this vein, there will be formation of varicose veins. Next, these are the points we have to draw for drawing the great saphenous vein. At the ankle lies about 2.5 cm anterior to the medial malleolus here. In the leg ascends by crossing the medial surface and medial borders of the tibia here. And at the knee it lies about a hand's breadth posterior to the medial margin of the patella here, this point, and in the thigh ascends obliquely on the medial aspect of the thigh to reach a point 3.5 to 4 cm inferolateral to the pubic tubercle, that is saphenofemoral junction. So you have to take 4 points for drawing this vein. Okay, next. Now we will go to the next vein. Next vein is the short saphenous vein. It begins by the fusion of a number of small veins below and behind the lateral malleolus. Here is the lateral side of the foot. Little toe is lying, so it lies below and behind the lateral medius. You have to remember, great saphenous vein lies anterior to the medial malleolus, and short saphenous vein is lying posterior to the lateral malleolus. Okay, so these positions are important. It begins by fusion of number of small veins below and behind the lateral malleolus, and here the vein runs with the sural nerve up to the lower third of the leg here. It along with this yellowish nerve is the sural nerve up to the lower third. And short saphenous vein runs upward up to the middle of the popliteal fossa. Behind the knee, this fossa is known as the popliteal fossa. So, short saphenous vein runs upward up to the middle of the popliteal fossa, and here it passes deep to the fossa, deep fossa, to enter into the popliteal vein. Okay, so it drains into the popliteal vein. Okay, next. So this is the course of the short saphenous vein. So it originates from behind the ankle region, joining of small veins, then ascends upward. There are some perforators connected to it, small veins, tributaries are draining into this small saphenous vein, draining the posterior aspect of the leg, and finally it reaches the posterior aspect of the popliteal fossa and pierces the deep fossa in the region of popliteal fossa and drains into the popliteal vein. Okay, in the short saphenous vein. Okay. Sometimes varicosity can also occur in the short saphenous vein. In that case, you may have to remove this vein via stripping, or there may be ligation may be required. Okay, so sural nerve is in the lower third of the vein. See here, this one is the sural nerve. Okay, lying in close relation with the short saphenous vein in the lower third of the leg. Now, lymphatic trunk, which drains the lateral aspect of the foot and drain in the popliteal lymph nodes, that also lies along with the vein. Okay. Next. Now, where the vein passes through the fossa, posterior cutaneous nerve emerges out from the deep to the superficial. Okay. So, in the upper part of the leg, this nerve in close relation with this vein, posterior cutaneous nerve of the leg, and in the upper part of the vein, it communicates with the great saphenous vein via the posteromedial vein of the leg. And short saphenous vein may run above the popliteal space and aid in deep veins in the lower thigh and may end in great saphenous vein in the upper thigh. These are different variations of drainage of this small saphenous vein. May drain in the upper part of the thigh, in the lower part of the thigh, or may drain in the great saphenous vein in the upper thigh. In the venous system, there are many variations. Okay. Okay, next. Now we go to the deep veins. Okay, deep veins. These veins lie in the deep fossal plane and are supported by the powerful muscles of the leg. That means they lie mainly near the muscles. Okay, and muscle contraction help in upward flow of blood through these deep veins. Okay. That's why gastrosoleus, gastrocnemius and soleus forming the calf muscles, they are known as peripheral pump. Okay, heart is the main pump for blood circulation through the body, and this gastrosoleus is known as the peripheral pump because it helps in drainage of the blood upward through these deep veins. Okay, through the muscle movement, this venous drainage occurs. Because the blood have to go against gravity, so more force is required for its drainage into the heart. So what are the veins included in deep veins? Anterior and posterior tibial veins, peroneal veins, these two are lying in the leg, deep vein. Popliteal vein lie in the popliteal fossa, and femoral vein, deep vein of the thigh. And these veins accompany with the arteries. Okay. Next, see here, this fibular vein is the peroneal vein. Here is the anterior tibial vein which is continuous, here it is continuation of the dorsalis pedis vein. Here is the dorsal venous arch, helps in formation of the great saphenous vein. Here is the great saphenous vein. draining into the femoral vein. This is superficial vein, and these are the deep veins. On the lateral side there is peroneal vein in the leg. Anterior aspect there is the anterior tibial vein, and posteriorly there will be the posterior tibial vein. And these join to form this popliteal vein here posterior to the knee joint, and here it will continue as the femoral vein in the thigh, and after that femoral vein will continue as the external iliac vein. Okay, and ultimately join into common iliac vein, and two common iliac vein will join to form the inferior vena cava. Okay, so that's how the deep veins are draining. Okay, understood? Okay, next. Now these superficial veins, the two veins we have learned, great saphenous vein and small saphenous vein, they are connected to these deep veins via the perforating veins. Okay, so these are the perforating veins. These are communicating veins between the superficial and deep veins. Two types of perforators are there: indirect veins and direct veins. Okay, next. Now, first we will discuss the indirect perforating vein. This consists of small superficial veins which penetrate the deep fossa to connect with the vessel in the muscle, and that in turn end in a deep vein. See here, this is the deep vein, here is the skin, and this is the superficial vein just underlying the skin in the superficial fossa. So it is connected with a network, venous network lying within the muscle. Okay, and this network is ultimately connecting with the deep vein. So that is the formation of the indirect perforating vein. Next. Now there are direct perforating veins. They directly connect the superficial veins with the deep veins. Here, this is skin. Within the superficial fossa, it is the superficial vein. It is connecting directly with this deep vein. Okay. After crossing this deep fossa or muscle. Okay. So these directly connect the superficial veins with the deep veins. Next. Now, what are the perforators? Perforators are very frequently asked in your theory. Okay, you prepare as a short note. Perforators. Okay, what are the perforators? In the thigh, there is adductor canal perforator. Here is the anterior perforator in the proximal thigh. This is known as adductor canal perforator. Adductor canal is also known as anterior canal. Okay, it is named after John Hunter. He first ligated the femoral artery in this canal. Okay, to prevent the blood loss during a surgery over the lower limb. That's why, according to his name, this canal has been named adductor canal. Okay, so adductor canal perforator connects the great long saphenous vein with the femoral vein here. In the lower part of the adductor canal, also known as anterior perforator. In the lower thigh, on the medial aspect, there is long saphenous vein connect the femoral vein via the Dodds perforator. Here is the location of Dodds perforator in the lower part of the thigh on the medial aspect. Now below knee perforator. Here is the below knee perforator known as Boyd's perforator around the knee. Perforator veins connecting the long saphenous vein or posterior arch vein with the posterior tibial vein. This long saphenous or posterior arch is the superficial vein and posterior tibial is the deep vein. So these two are connected by this Boyd's perforator. There is a below knee perforator. Okay. So three perforators we have discussed. Next in the leg, there are lateral perforators is presented at the junction of the middle and lower third of the leg, and it connects the short saphenous vein with the peroneal vein. Peroneal vein is deep vein on the lateral side of the leg connected with the short saphenous vein by the lateral perforators at the junction of middle and lower third of the leg. And medially, there are three perforators which connect the posterior arch vein with the posterior tibial vein. These are known as clockwise perforator. Which veins they are connecting? That is also important. Okay. So, three perforator veins are present connecting the posterior arch vein, superficial vein with the posterior tibial vein, deep vein, also known as clockwise perforator. Three perforators are there. Okay, next. So, these are the three perforator veins. On the medial aspect, clockwise perforator connecting the posterior tibial vein with the posterior arch vein. And here is the, on the lateral side, will be the another perforator connecting with the peroneal vein. So, these clockwise perforators are three in number. Upper medial perforator lies at the junction of middle and lower third of leg. Middle median perforator lies 4 inch above the medial malleolus, and lower medial perforator lies posterior inferior to the medial malleolus. These are the location of these three perforators, clockwise perforators. Okay, next. Now, if in case of incompetency of these perforators veins have valves, okay, and they direct the blood from superficial to deep veins, okay, and prevent the backward flow, so that blood does not pull in these superficial veins, okay. These deep veins, the blood drains through the deep veins via the action of the muscles, okay. So, if there is incompetency, that means there is connection is lost between the superficial and deep veins, the blood will be pulled in the superficial veins, or if there is retrograde flow, that means during upward flow, if the valve is incompetent, blood flow from deep to the superficial vein. In that case also, there will be pooling of blood in the superficial vein, and the superficial veins will become dilated and tourniquets according to the position of the perforators, and you can determine which perforator vein is incompetent. Okay. And if the varicose vein becomes severe, then you have to do ligation of the vein or stripping of the vein. Ligation of incompetent perforator can be done by these three methods: open subfascial ligation of perforators, and subfascial endoscopic ligation of perforators, and extrafascial ligation of perforators. These are the treatment modalities, surgeries. Also, sclerotherapy can be given. Sclerotherapy means one agent is injected into the vein, and vein will be fibrosed after the injection. Okay, so there will be no collection of blood in the vein, and varicosity will disappear. Okay, so another treatment method is sclerotherapy. It is done when it is not very serious. Okay. Now, endovenous laser ablation, this is also done to destroy the dilated tortuous vein. Also is radio frequency ablation. Okay. So, these are the treatment modalities for the varicose veins. Okay, next. So, when you will do the ligation and stripping, indication is long saphenous vein and short saphenous vein incompetency. The varicose portion is removed, okay, via this stripping operation. And perforating vein incompetency, okay, also in this case you can do the ligation and stripping. Okay, next. Next, and contraindication, in which cases we will not do this stripping operation. Okay. So, deep DVT means deep vein thrombosis. Okay. Here you cannot do the deep vein thrombosis, means there is a blockage in the deep vein. Okay. So, if you remove the superficial vein, blood will not be able to drain. Okay. So, deep vein thrombosis also in pregnancy. In pregnancy, there will be compression over the veins due to the fetus. In pregnancy, normally in some patients there may development of varicosity, okay, due to pressure over the veins. Thrombophlebitis, that's an inflammation of the vein, and peripheral vascular disease. peripheral vessels, veins, very small veins and arteries are important. So in these cases, these are the contraindication for the stripping operation, okay, of the vein. Okay. Okay, that's all for today. Any queries? So you have to prepare great saphenous vein very clearly, prepare for a short note or long question, and it is also given in your OSPI. Great saphenous vein tributaries are very frequently asked in your viva, and short saphenous vein can also come as a short note. Okay. And perforators, deep veins you have to know to see the connections. Deep veins you will learn during the dissection class. You will see the deep veins, okay, and you have to very perforators are very important. You prepare it very well. Prepare a short note and practice a schematic diagram for the perforators and also the great saphenous vein and its tributaries. Okay, understood? So these are important for your questions. Okay, that's all for today. Okay, thank you all. Okay.
Essentials of practical biochemistry, one book, one chapter, and I wanted to give it to your groups. Has everybody received that same? Have you received? I told yesterday, I shared. Huh? Yeah, it is to be circulated to the group, to your batch. See, I have written many articles on diabetes, and today I will be covering on diabetes by WhatsApp, and that is in Bengali. Just put on the click on the right one. A. This was written sometime in 1996 in Sarodiya Sayok. There is a. This was in Bengali. Those who cannot understand Bengali, I will try to translate by the end of this month, and I will give it. You need not worry. Only thing is that this is written in the very simplest form, and you must know this thing because many patients told me, and I tried to educate them, and that was an endeavor. Second, see, I will be discussing what is the criteria for diabetes. Till 1994, there was no information about what the normal value is. One was on diabetes, one was on impaired glucose tolerance test. Now today I will be discussing what the normal value is, because at that time it was not clear. Whatever. This is the current criteria. This was written at the end of that book which I have added. See, once it will be given to you, it will be clear to you. This book was published from Sir Gangaram Hospital and AIIMS New Delhi, and I contributed one chapter in the year 1991, that was on liver function test, and the second chapter was in 1994 while I was in Durgapur, and this book was published sometime in 2002. Now there is a request from that author, both were HOD, that Dr. L.M. Srivastava was my examiner, MD examiner, and Dr. Sinha took over the charge from the year 2002. So there was a request to me by Dr. Srivastava to write the revised chapter on both the topics, and I submitted on 2016 in the month of July. That revised chapter was, see, try to maintain the decorum, otherwise the camera will focus to you. I am running short of time, there are many things has to be covered. So read that topic and keep that document with you. You will be requiring those informations during your clinical years. So today I will be discussing about diabetes, and I will be sharing one more information today by WhatsApp that I recovered from my archive, from my book, that is information to the diabetes patient. See, I will be covering today on diabetes. It's a very common disease, many of you have heard. I don't think that in this hall, at least, there is nobody who has not heard the term diabetes, and I think there will be some families where some diabetes patients are there. See, diabetes mellitus is a disease which was known before almost 1500 years before Christ. It's a very common disease. But the problem is that the amount of information which is available on diabetes, if I allow to keep this book in this hall, that will be filled up. The problem is that it's a very common disease, but it's a very poorly understood disease. And that is the reason it is just like a blind man describing an elephant. There is no dearth of medical experts on diabetes, but nobody can cure. Prevention is the mainstay, and control of the disease is in the hands of patient only, mainly. Doctors do not have that much role to play. So today, basic intention of this class is to orient you to the clinical spectrum. But at this stage, you must know the biochemical basis, and there will be 2, 3 or at least 4 slides which I would want to you to note down, because that will be clinically relevant and that will be required throughout your career, particularly for examination purposes, and that you must note down. Rest of the things you hear for orientation purposes. So diabetes, basically that word come from Greek word. Most of the medical sciences word came from diabetes, Greek and Latin. So originally passing too much in the urine, that is diabetes, that particular terminology, because at that time diabetic patients go to the toilet, they pass urine very frequently, and the militas that term was, the meaning is sweet. So it was known for the first time sometime in Egyptian manuscript. At the same time, people from India, but Indian physicians, they also described it, but the disease name of the disease was Madhumeha. That means it is attracting the ants, because honey, meha means honey, madhu means meha, madhu means honey. So that used to attract the ants, and that's why the term was diabetes mellitus. So to blood sugar is a very common, loosely used term. It's a time honored. Ideally, we describe basically glucose by blood glucose. Actual blood glucose is measured by glucometer, that small instrument which we will be using in the ward. But in the laboratory, we do not measure blood glucose nowadays. It was done before 2000. We measure plasma glucose. We centrifuge the samples and then we take the plasma. From that plasma, blood glucose is maintained, blood glucose is measured, and that is the standard laboratory procedure. Serum glucose is not measured. The reason I will discuss in the small group discussion, we just raise this issue, why serum glucose is not recommended. During description of any disease of the blood, you will term MIA. This particular word is here we used. So if there is a less hemoglobin, that is called anemia. Yesterday somebody was talking about thalassemia. This is a very big chapter, at least 1 4-kilo book is there, that is called thalassemia syndrome, and I had a very huge number of collection on thalassemia. Anybody interested, I can provide the data. Similarly, if there is excess of RBC, that is called polycythemia. So with respect to diabetes, the terms used to describe glucose level in the blood, it is glycemia. That means presence or level of glucose in the blood. So there are 3 terms. One is hypoglycemia, that is low blood glucose level. One is normoglycemia, that is normal blood glucose level. And third one is hyperglycemia, that is high blood glucose level, and that is relevant to diabetes. Hypoglycemia is the most dangerous condition and it's a life-threatening condition. I will discuss at the end. So diabetes mellitus patient suffers from hyperglycemia. So what is diabetes? Just write down this thing. It's basically a group of common metabolic disorders that share the phenotype of hyperglycemia. Hyperglycemia must be a feature for diabetes. So that definition, see what is diabetes? You try to define this thing. Diabetes mellitus is a group of, write down this thing. Diabetes mellitus is a group of metabolic disorders characterized by hyperglycemia and diagnosed by the following. These you must write. There are the 3 terms. One is fasting more than 126 or equivalent. PP, that is postprandial after 75 grams glucose is 200, more than or equivalent to. And HbA1c, I will discuss a little later what is the HbA1c. More than 6.5%, and that's the diagnostic criteria. So while we are doing the PP blood sugar, which I will be discussing in the SGD group in detail, there should not be any calorie intake for at least 8 hours. It is usually from 10 to 14 hours, and blood is taken after 2 hours after 75 milligrams glucose. In the absence of unequivocal hyperglycemia, two abnormal results from the same sample, there will be many situations where you have to examine a patient for medical fitness. And if diabetes is there, is a criteria of unfitness, on the day of examination, that particular report is most important. If there is a system to take blood for fasting, and if you find that blood sugar is more than 126, the patient is diabetic. On that particular sample, you do the test twice, thrice. Do not ever try to do the test on the second day, because the patient will have a control or take a medicine and the blood sugar will be normal. On that day of investigation, if you whatever investigation you want to do this test. If you want to do PP, that is 200, or the patient might come at a later date with a legal case also. In that particular case, you do an HbA1c. That figure cannot be controlled. Why? I will tell in detail. So, two abnormal results from the same sample, you just repeat the same sample, or two separate samples. If any of the two satisfies, then it is a diabetes case. Now, once diagnosed, the patient usually tries to have a control on the diet or take medicine, and on the very next day he will come, and in that case you will get a normal report, slightly less report, or even a normal report, and in that case medical fitness has to be given. So, don't forget this thing, this is very much important. As you go in the hierarchy, in the seniority, you might be chairman also, and you have to take a decision on that. That happened with me. So, clinical features, common clinical features you must remember, that there is a common perception that there will be polyuria, means multiple times the patient will pass urine. Normally, whatever the frequency is there will be polyuria, increased frequency of urination, because high amount of glucose will be excreted in the urine, and glucose being an osmotically active substance will draw water, and that is the reason why polyuria occurs, because since the huge amount of water will be excreted through the urine, patient will feel thirsty, and that is the reason he will drink water, and that medical terminology is polydipsia. And third important, polyphagia. Patient will try to take the foods frequently, because he will feel hungry, because cells will not be able to utilize glucose. Since the cells will not be able to utilize glucose, patient will have a weight loss. So, unintentional weight loss. We do exercises, suppose we are overweight, we want to decrease our body weight, we either take less amount of food or do an exercise so that we lose weight. But many a time, patient might lose the weight, and when the patient is losing weight, at least three things you must remember. One is diabetes, second one is cancer, and third one is hyperthyroidism. So, unintentional weight loss suspicion, first suspicion will be diabetes, and second will be cancer. Then blurring of vision, because lens is put in the aqueous humor, and there is a glucose level in the aqueous humor. Now, when there is hyperglycemia, there will be more amount of glucose in the aqueous humor, and that will cause alteration of the volume of the lens, and that is the reason why blurring of vision will be there. Chronic recurrent infections, that I will show it, boils, abscesses, even delayed or improper wound healing, and if that happens in a patient, you must suspect that whether the patient is diabetes or not. Asymptomatic. patient may not develop any symptom at all. In the vast majority of the cases, diabetes is detected on casual routine investigation. Suppose in this in your 3 of your batch, what I told yesterday also, that if I try to analyze all the 450 students, all will not exhibit normal level of blood glucose. Some will have some amount of impairment. Maybe 1 or 2 will be detected to be diabetic. Because you are all from affluent society, I know, a section of the society I know, you take much amount of food, do less amount of exercise, and that is quite common. Believe me, what happened in our hospital, the HOD of medicine was admitted in ICU with a chest infection, and an undistributed physician in our hospital, and what blood sugar was sample sent to us, and the fasting blood sugar level was 550. I went to the ward, I went to the ICU and told, sir, your blood sugar is 550. It's a very high amount of blood sugar. That is quietly admitted, informing that that is the reason why my infection is not responding to antibiotic. So he, being a physician, dealing with patients, treating patients, totally unaware that he is having diabetes, and that to such a significant extent. And second thing, this was a story of 1994. And second story was again a director who came along with his wife to have a blood sugar testing. His wife's blood sugar testing was fasting 110 and PP was 112, but his blood sugar fasting was 380 and PP was 550. He could not believe. Then he tested urine and it was positive. So being a director of this hospital, having vast experience treating patients, still they were asymptomatic. And in a short while I will show you how asymptomatic is that, and the patient do not want to accept it, that I am having diabetes. And most of the patients, I repeat, develop the disease slowly. That's why their body gets adjusted and they do not suffer from any symptom, and on casual investigation diabetes is detected. Patients might present with complications of diabetes mellitus, and what complication I will show a very glimpse about it. See, in the OPD patients in my hospital, see, this was the date on which the actual investigation was done. On the first investigation, fasting blood sugar was 400 feet, 69 and 710. He was the engineering working in the plant. I inquired and I brought the patient from that particular individual from the plant itself. And the random blood sugar was taken, it was found to be 672, and his mental functions were all 100% correct. I gave a difficult mathematics and he did it immediately. And what that mathematics is, I will tell you. Second case was again IDDM, that is insulin. The patient was taking insulin. He is a very good chemistry teacher. He came by motorcycle driving and his blood sugar was 664 and 682. I took him and dropped him with my own car. I did not allow him to drive motorcycle because I knew he might sustain an accident also. See, in the gynae department, first investigation you see 459, 874. The patients were not aware that they are having such a high blood sugar level. Again, gynae first investigation, frequency of micturition, there was a symptom, 390, 640. And this is a case of diabetes mellitus with CRF, that is renal failure. The blood sugar level was 610 and 945. The highest level of blood sugar I have seen 1998. And the patient gave the blood and went home. I literally contacted that patient, contacted her husband, and got the patient admitted and allowed for treatment. That's the responsibility you must have. Physician wants to accept it, but this is a hardcore truth that most of the patients do not have any symptom. So patient will present with this type of features. With experience, you will see once by looking at the infection itself, you will have a doubt that the patient is having diabetes. Let us have the blood sugar estimation first. Until and unless you control the blood sugar, infection cannot be cured. So there will be sheer failure of infection even if you give antibiotic injection. So this is a style. So these type of wounds, with experience you will know this is fungal infection in the mouth, this is fungal infection within the vaginal canal. It will be having a card-like appearance, you will see it in the word, and you see this type of infections usually doesn't occur normally, but occurs in diabetes patients. So, but just by looking at the wound, you will have a suspicion. So, there are criteria for diagnosis. Earlier, WHO used to make the criteria, and that's what was written in my Sarodiya Sayak book. They gave the information in the 1985 first and then 1994. Both technical series reports were there, and what was written in that was written in my Bengali literature. And later from 1997, the American Diabetes Association came into the picture, and they give guidelines every year in the month of January. In this year 2024, the guidelines are available, and it is the same guidelines which was followed from 2004, particularly the diagnostic one. Many things are changing, they are updating every year. And fortunately, these data, the WHO latest information was on 2020, and American Diabetes Association is giving the same information from 2004 to 2024. Yesterday I checked it. January issue has already been made available in the internet, and this is the same criteria. You must write this thing. You have to remember this thing. See, for such a pretty long time, the same feature, same diagnostic criteria is there. So, what is normal blood sugar glucose level? That is less than 100. There is a catch point, less than 100. What is the lower limit? That was not written, that was my area of research. I have done some work on that. I will show it in the SGD. 2-hour PP, again less than 140, that is another catch point for me, that what is the lower limit. I worked on that. HbA1c facility was not there, I could not carry out. So, this level less than 100, less than 140, less than 5.6 is the normal value. And this is the value which I told you earlier for the diabetes. So, it doesn't develop overnight. So, there will be a gray zone from normal to diabetes. So, that is called impairment or pre-diabetes. That is from, see, it is less than 100. So, 100 to 125 will be the pre-diabetes stage. Here it is 140. This is, you see, 200 year equivalent. So, 140 to 199. And HbA1c is 6.5. So, this is the range. The importance of this phase is that, see, many of you, or I don't want that some of you or many of you must have, I want that everyone have the normal value. But on investigation, if any patient is found to be in this stage, now if an extensive control is made, this stage can be brought to this stage, that is from impairment to normal. But those who are having diabetes already, they can be brought from this stage to this stage, impaired stage. But it will be very difficult to bring them to normal stage. And that is the reason why periodic evaluation is required. At least for the aged patient more than 40 years, it is recommended that you get the blood sugar investigation done every year, so that the disease can be diagnosed at the earliest possible date and you can have a control. So, classic symptoms of diabetes, that is polyuria, polyphagia, polydipsia, whatever I have told, and along with the random blood glucose, if it is more than 200, that is diabetes. Slide that help korte tale hobe na. So, types of diabetes mellitus, the WHO has given a very big list. Better remember this thing, ADA 2020, type 1 is diabetes mellitus, type 2 is diabetes, type 1, type 2, at least you must be able to tell this thing, and there is another type, that is specific type of diabetes mellitus due to other causes. I will tell in detail. And third one is gestational diabetes, this is during pregnancy. So, there are 4 entities, at least you don't try to remember. Next one, this is a WHO criteria, this is a very big list, don't bother your head, because as you grow in the higher ups, in the senior level, that at that time you will know this thing. So type 1 diabetes, you just write down this thing. That's the minimum information you must have. So type 1 diabetes, it is an autoimmune beta cell destruction. So pancreas, insulin is secreted by the beta cells, and there is autoimmune destruction. If the cells are destroyed, then they will not be able to produce insulin. So there is absolute deficiency of the insulin, and the patient will require insulin treatment. Nothing will work in that patient. In contrast, the type 2 diabetes mellitus, which is very common, it comprises 95% of the patients, and day in, day out, you will see this patient, this type of patients. That is type 2 diabetes mellitus. Is a non-immune progressive, non-autoimmune progressive loss of adequate beta cell secretion. There will be no problem with the beta cell itself. There will be some destruction, but that is a very gradual process. The basic problem here is insulin resistance. Insulin will not act properly on the peripheral tissue, unlike normal individuals. And the specific type of diabetes due to other causes. You just note down the term, otherwise you forget this thing. Monogenic diabetes syndrome or neonatal diabetes, and MODI, that is maturity onset diabetes of the young. Many young people nowadays are diagnosed to be having diabetes. So that is MODI, it is called, that is maturity onset diabetes of the young. And since beta cells are in the pancreas, so any disease of the exocrine pancreas, that is cystic fibrosis and pancreatitis, indirectly will affect the beta cells, and that will cause diabetes. A drug or chemical induced diabetes is glucocorticoids. Remember, on many situations, you will be giving steroids. And once you plan to give steroid, first rule out whether the patient is having diabetes or not. If the patient is having diabetes, try to exercise extreme caution on using steroids. You must know that blood sugar will be elevated. You make the patient avoid it, and if you allow the glucocorticoids to continue, you will cause iatrogenic diabetes. That means that disease is caused by you, caused by the physician. That disease which is caused by the physician is called an iatrogenic disease. So iatrogenic diabetes is commonly caused by glucocorticoids, and gestational diabetes means the patient, that lady was not diabetic before pregnancy, but during second or third trimester of pregnancy, the patient was diagnosed to be having diabetes. And why? Because pregnancy is a stressful condition. During stress, that body could not cope up with that glucose load, and they develop diabetes. If any gestational patient was diagnosed to be diabetes mellitus, some of them, if they don't take proper precaution, are going to develop diabetes in future. Because once stress was there and she responded very badly, and that is an indication. And for gestational diabetes mellitus, you just warn the patient that you take extreme exercise caution so that you don't develop diabetes in future. Because in future they might be pregnant also, and that will be disastrous consequences of the pregnancy if the patient is having diabetes. And diabetes is basically is a disease which doesn't spare any organ of the body. It will involve the entire body. Next. So there is difference. You just remember that type 1 is a complete beta cell destruction, and type 2 beta cell dysfunction is there. There will be loss with the passage of time, and in course of time, these type 2 diabetes mellitus, when the insulin beta cell secreting cells will be completely destroyed, at that time it will require insulin. So diabetic patients, these type 2 diabetes mellitus, in the initial stage, they can be controlled by diet, they can be controlled by exercise, they can be controlled by oral hypoglycemic agents, but at the end of the life, when the beta cells will be destroyed, those drugs will not be acting because there is no beta cell. So circulating insulin level, if you measure that type 1, it will be deficient and it might be absent also 100%. But here it is normal or slightly elevated because insulin is not acting. The onset is first year, it takes time to develop, and that is the reason why the most patients remain asymptomatic. If the body gets adjusted, suppose if you are walking today, say 20 staircase, now next day if you climb 21 stair, body will not appreciate that. Now if you go on increasing, one day you can cross the 50 staircase also, but you will not feel it. That is the reason body gets adjusted to any alteration. That's an adaptation. That's a normal physiological process. So this 5% of the cases you will see the type 1 diabetes, and it's a miserable condition in any family. It's very the young. It happens in the younger age group, usually teenage group, and you cannot imagine the degree of sufferings of the parents. And most of the patients are in the 95% group. So your basic patients will be, majority of the patients will belong to this type 2 diabetes mellitus. And body habitus, it is usually lean. You cannot lose the body weight, allow the patient to lose the body weight at any cost, insulin has to be given. But here the patient is usually obese, he is having a high body mass index and abdominal obesity. Its previous name was insulin dependent diabetes mellitus because insulin was absolutely required. As this type 2 was non-insulin dependent diabetes mellitus. As I told you, the age is most common in childhood or early adulthood. Now see, imagine a patient in today's life, we are having 1 or 2 child norm. If the patient, that child is diabetic, then imagine the condition of the parents. The patient will, the baby, that child will suffer, as also the patient. And it is often diagnosed in the midlife. That's why I told that there will be a yearly checkup after 40 years. Next particle. So secondary diabetes mellitus, the importance of this thing, normally diabetes is not curable. But secondary diabetes mellitus, if you remove the cause, diabetes will be cured. Suppose this is a pheochromocytoma, this is a rare tumor of adrenal medulla. If you remove the tumor, then the causative factor is out, diabetes is out, clear. Second is Cushing syndrome. It's a tumor of the adrenal cortex. I have seen one case, Cushing syndrome. Cushing's disease I have not seen. It's an adenoma of the pituitary. This Cushing's disease, pituitary gland is secreting ACTH. If that ACTH producing cells undergo tumor formation, that will produce excess amount of ACTH that will indirectly cause high amount of corticosteroids, and that will cause diabetes. Hyperthyroidism, acromegaly. Only last week I saw one patient who underwent a microadenoma operation of the pituitary 3 years back at the age of 45 years. So microadenoma or adenoma of the pituitary gland, which is producing growth hormone, is a cause of diabetes also. When you will read the hormone chapter, at that time you will understand why diabetes occurs. So the importance of this thing is that whether the diabetes is primary or secondary, your job will be to first identify whether there is it is not due to secondary cause. If it is secondary cause, you are in a safe side, the patient can be cured. And if you don't treat these patients, patient will be presenting with a late stage, and it will be their life will not be that easy. It will not be easy to handle. Next. So laboratory investigations. So once diagnosed, it is diagnosed diabetes. Usually based on the level of the blood sugar, usually these tests are done and at a variable interval. But depending on the socio-economic condition, resource available, and the patient's capability also, you can have some amount of changes, maybe 6 months or 1 year interval, but go on monitoring. Monitoring of these parameters are required. HbA1c. Today we are having a fascination of HbA1c. Those who are having diabetes, Even if before the doctor suggests, sir, Dr. Will I get the HbA1c done? Yes. The patient, if the moment they say the HbA1c, yes, why not? I will tell you why the HbA1c. See, if you take a fasting blood sugar sample, it is given at a particular point of time, right now, today at 10 o'clock 40 minutes, 10:40 we are drawing the sample. At a given point of time, what is the blood sugar level? That is measured. Similarly, postprandial means after meal. If I take say 12:40, that will give exactly that amount at that point of time. But if you take the same blood sample on the next day, tomorrow, it may or may not give the same figure. It is just like rainy season. On the preceding day at 10 o'clock there is a heavy raining, on the next day it may not rain. Or it may rain, you cannot predict without observing. In contrast, HbA1c is a long-term assessment of last 10 to 12 weeks or 2 to 3 months. It's a long-term assessment. So if you don't do this fasting blood sugar, PP blood sugar, but if the HbA1c level is high, that means that patient was maintaining a very high blood sugar level for a quite long time, that is of 2 to 3 months. So that is a glycated hemoglobin, as Sir told yesterday, that hemoglobin part, HbA1, A2, hemoglobin A. So this is a glycosylated hemoglobin, that is HbA1c. Write down this part. Depending on the blood glucose level, this will be asked to you at this stage. This is basically biochemistry. Alpha amino group of N-terminal valine moiety of beta chain of hemoglobin is non-enzymatically glycated. I will show you the picture, and that forms a skip base. Initially, when the ambient blood glucose is maintained for quite some time, that is albumin form is formed. Now, if that level is maintained for quite long time, then albumin form gets converted to ketamine form, and that is what is HbA1c. So it's a measure of basically beta 1 N1 deoxyfructosyl component of hemoglobin, and the reference method is HPLC, that is high performance liquid chromatography. Just like glucometer, HbA1c meter is also available, but that will not give you the correct figure. So if you advise HbA1c measurement in any individual, advise go for HPLC. Don't accept other methods. That's a reference method. So that is a skip basis formed. Some examiners might ask you, if you answer well, otherwise no. That glycated hemoglobin, if you say, that will be okay. So basically, as I told you, that D-glucose, you see there is a aldehyde, this is a ketone form, this D-glucose is there, amidary rearrangement, and ultimately a ketamine form will be formed. This is aldehyde group, and in course of time, when it is a ketamine form, this aldehyde is formed into ketone. That is. Now, why HbA1c? Because HbA1 constitutes 95% of the hemoglobin, and HbA1 is 85%. There is a maximum amount, and that is the reason why HbA1c is considered, not the other HbA1A, A1B is there, A1C is also there. So this is present in the maximum concentration, and most of the molecules belong to this group. So once you measure the HbA1c, you can have a rough estimation about what the blood glucose level was there. Write this thing. Just by looking at that particular figure, you will be able to have an idea what was the blood sugar level, blood glucose level in the previous 2 to 3 months. See, this 6, it will correspond to approximate blood sugar of 126. Now go on adding 28 or 29 with each percentage increase of HbA1c, you will have an average glucose concentration. So on a given day, suppose today, if my blood glucose level is fasting is 100, PP is 140, I will be absolutely normal, and I will want to take sweets because my blood sugar is normal, But if A1C is done, if it is 12%, that means you are telling a lie. Yesterday you have taken a good amount of medicine to befool me, or you want to take some amount of sweets, and that's a common practice. So complications, there are two complications. One is acute complications. Patient will come to the emergency department. One is hyperosmolar hyperglycemic state. Earlier we used to, when we were students, this terminology was not there. This was called non-ketotic coma. And second one is diabetic ketoacidosis. Now there will be angiopathy, both microvascular and macrovascular. When the large vessels are involved, that is coronary artery or cerebrovascular artery or peripheral artery, that is called macrovascular complications. And you know the myocardial heart attack or brain stroke, that is due to macrovascular complications of diabetes. And microvascular eye, in eye or nerve or in the kidney, there are small vessels are there within that particular organ. So there you will get microangiopathy, and that is observed in the form of retinopathy. You can diagnose the case by looking at the retina, ophthalmoscopy. And the first suspicion will raise, I will show you the picture. Once you see this thing, there will be no problem, and there will be some complications of diabetes. And patient may come with this stage, with neuropathy or with nephropathy. Or the patient might present with heart attack or stroke. First investigation again, the blood sugar. Infections, diabetic foot, as I have shown, I will show you some more picture. Diabetic gangrene, the leg needs to be amputated. It is such an infectious material will be there, toxic materials will be there in the body, life will be at stake. Hearing loss. If an aged person presents with hearing loss, rule out diabetes first until proved otherwise. Many persons, out of fear, psychosis, or many doctors over-treat the patient, and that leads to hypoglycemia. Aggressive control of blood glucose level will lead to lowering of blood sugar, and that is a dangerous condition. So, patient can at any stage cannot be controlled to the extent of hypoglycemia. So, hyperosmolar hyperglycemic state is when the blood glucose level is very high, because hyperosmolar is a very high concentration, so it will exert a high amount of high osmotic pressure, so more water will be drawn. So, it is usually in the range of 600 to 900 milligram, but I have shown you the picture that even at that stage, body gets adjusted and they can move. They are driving motorcycle, they are coming to the hospital, but they are not having hyperosmolar state, and it usually occurs in the older persons. Uncontrolled diabetes, extreme lack of drinking water. Old patients don't really care for, they are having less alertness. Sometimes they are forgetful. They take less amount of glucose, they don't take medicine, they forget medicine, either they take too much or they forget it. You cannot blame them, it's a problem of the brain. So they present with hyperosmolar hyperglycemic state, and it is due to osmotic diuresis. Why osmotic diuresis? Because urine will have a high concentration of glucose and that will draw water, and that will leads to water and electrolyte depletion. There will alert consciousness because brain cells will be dehydrated, because again brain cell is exposed to certain amount of glucose, and if the concentration of the glucose is very high in the cerebrospinal fluid, the blood cells will suffer from some amount of dehydration, because that water will be drawn from the brain cells into the cerebrospinal fluid. So there will be severe dehydration. Even if the brain doesn't function properly, some amount of neurological deficit will be there. Either the patient will not be seeing properly, or they will having some amount of neurological problem somewhere. Either right hand, left hand weak, right leg, left leg weak, or some form of neuropathy. But the diagnostic point here, ketone bodies will be negative. In contrast, type 1 ketoacidosis, diabetic ketoacidosis is common in type 1 and develops within a short span of time. Glucose is available in the plenty in the extracellular fluid, but cells are not able to take up glucose from the plasma or from the peripheral tissue to the cells, because effects of insulin on enzymes are absent. Once you know the metabolism, the key enzymes of metabolism, which I will discuss in a short while, so there will be delay in the metabolism and the cells will undergo starvation despite having adequate amount of glucose within the body, within the blood, in the tissue fluid. Cells will not be able to take up glucose and it will not be able to metabolize glucose just like a normal individual, and that will cause starvation, cellular starvation. There will be two differentiating points. One is that the commonest cause of ketoacidosis is one is starvation and the second one is diabetic ketoacidosis. In starvation, there will be real deficiency of glucose because he is not taking food, so glucose is not available in the system. But here in diabetes there is abundance, but cells are unable to use it. So at the cellular level, the picture will be the same. Only thing is that the metabolic key enzyme activities will be different. And there will be differentiating, salient differentiating point between starvation ketoacidosis and diabetic ketoacidosis. So there will be insulin deficiency, there will be increase in the counter-regulatory hormones, that is glucagon, catecholamine and cortisol, metabolism of triglycerides and amino acids, glucose for energy. This you write. This part all of you write. This is the key metabolic enzymes and the effects of insulin on enzymes. Insulin is the only hormone which decreases blood glucose level. Other hormones increases. So how insulin decreases blood glucose level? These are because of the excess of the key enzymatic activity of the glycolytic pathway and neoglucogenetic pathway, even glycogenesis and lipogenesis and protein synthesis also. So some will be stimulated, some will be inhibited, and that is the reason why during deficiency of glucose, blood glucose level becomes high, and if you treat excessively, insulin level will be high and blood glucose level will be low. So this is important biochemically, and second, two more slides I will show you that you must write down for understanding purposes, or I will give you this part. You can note it down because now right now it is almost 5 minutes to 10 o'clock. So biochemistry of ketoacidosis. This much part you write down. I will give you this slide later, so you can note down, or from the video recording you can note down this part. This part you write down from the video recording because this will be available, and write down this part. Even if you cannot write, you see that is the basic biochemistry of diabetic ketoacidosis, and that will be asked. Sometimes the case will be given and discuss the biochemical basis of ketoacidosis, and this is what you have to write. And the difference between diabetic ketoacidosis and hyperosmolar syndrome, it is the simplest, and a single chart you will understand the difference between the two. Once you complete the metabolism chapter and the key enzymes involved in it, just open the Harper book. See all the metabolic cycles are very well described and try to memorize it. Key enzymes, regulatory path. Maybe other books are written, but I have read in Harper book. At least metabolic pathways, you read the cycles from Harper, and then you see the role of insulin, and finally you read this chart. The best way of description, simplest way of description, both the things together I have compiled. Causes of complications, why complications in diabetes occurs? It's availability of less glucose inside the cell. There will be glycation of protein and sorbitol. Sorbitol formation within the cell is the cause of both diabetes and galactosemia also. So there will be medium-sized vessel, plaque formation, thrombosis, microangiopathy, cataract, neuropathy, nephropathy, all are due to sorbitol formation. So this part you remember, these 3 lines you write down. So it's due to polyol pathway. Normally this pathway is not activated. It's remain dormant. Only it gets activated when there is excessive accumulation of glucose more than what is desired. So this is not active in liver, and this I tell that this is normally remains dormant. But its activity is increased in tissues not insulin sensitive. That is lens, that's why we see the problem in the lens, vision, peripheral nerves, that's why we get neuropathy and renal glomerulus, because we have diabetic nephropathy. And this is because of sorbitol formation. And this part you remember, that glucose is converted through the adsorbed reductase enzyme to sorbitol. And sorbitol is a metabolically active substance. It absorbs water and the cells undergo swelling. Similarly, for galactosemia, galactose gets converted again by the aldose reductase to galactitol. And galactitol is also a sorbitol. It's an osmotically active substance. It will draw water. The lens will undergo swelling and it will form cataract. So this is a diabetic retinopathy picture. Once you do this is very well seen, I have seen it. Once you put an ophthalmoscope, you will be able to see the retina. This type of picture you can get in hypertension also. Only problem here it is that if you see a microaneurysm, that is diagnostic of diabetes. Microaneurysm doesn't occur in hypertension. And the exudates, that will be hard exudate in diabetes, but soft exudate will be there in hypertension. So just by looking at the retina, you can diagnose, being an ophthalmologist, the patient is suffering from diabetes or not. So diabetic foot, see the picture. See, if this type of things are there, the entire leg becomes black and the legs needs to be amputated. This doesn't happen overnight, as you can understand. It's a chronic negligence. And that's why this is the picture. So hypoglycemia is the most dreadful complication and it's a life-threatening condition. And once you diagnose, a life can be saved by simple administration of glucose or sweet or chocolate even. I saved a patient from in our village 6 years back. He was totally comatose. Over telephone, over mobile, I instructed a village quack and rescued the patient. He started talking and taking food in the lunch. It happened at 10 o'clock when the patient cannot be aroused from sleep. Patient was in deep coma and the blood sugar level was less than 40. From glucometer, they had a glucometer. I told them to measure the glucose level. And the patient was under insulin treatment. And I treated this patient without instruction, because what treatment is to be given, if you know the biochemistry, then only you can treat it. So normally body doesn't. Sir, what is the time right now? 11 বাজে just 5 মিনিট 7 মিনিট সময় নিয়ে যদি একটা ভিডিও দেখাবো ভালো লাগবে. Just wait for this thing. Otherwise, I will cover it in the practical class. I will cover it in the practical class. So, patient education is very important. One thing we don't do it. Being a doctor, once a patient, please listen. One video I will show after this thing. Patient education is most important because diabetes can be controlled by the patient, not by the doctor. Your success will depend on patient education. Spend a little time on the patient, teach the patient to accept the disease. Please keep quiet for 5 more minutes. Teach the patient to accept the disease. Most of the patients don't want to accept the disease that I am having diabetes because they are not having symptoms. Stick one system of therapy. Once the patient is diagnosed with diabetes, he will disclose that I am having diabetes, and there is no dearth of medical experts in abundance. They are available in abundance around you. They will start you, go to homeopathy, go to Ayurvedic, go to Patanjali, this, that. Whatever, I have regards for every system of medicine to ask the patient to please stick to one system of therapy. Don't mix it. Homeopathic and allopathy, homeopathy and Ayurvedic, homeopathic and Patanjali, no. If you have a belief, go for that system. Relevant information to the patient, that is one part. Please teach the patient, please tell the truth. Because all the chronic patients are habitual liars. Remember, they will misguide you. So in the first instance, please tell the truth what has happened. Then compliance to diet, you show the importance to the diet, medication and exercise. The entire world is following a bad norm of exercise. They exercise in the morning when the blood glucose level is low. This is not the ideal time, I repeat. Exercise has to be done at least 1.5 hours after, 1.5 hours or 2 hours after food when the blood glucose level is high. And I explained to HOD, I mean 2-3 months back, and he accepted my view. Walking during empty stomach is dangerous because already there is low blood glucose level and you are tightening it. That will not going to solve the problem. Regular monitoring, storage of insulin. All persons do not have fridge, remember. So you have given the insulin and insulin will not be stored properly. Patient will take insulin injection, but the diabetes sugar level, blood sugar level will be not maintained. So teach how to store insulin and individualize glycemic goals. There are many things written in the book. You must know what is the patient profile. He is a day laborer, he is working, he is a driver, he is a driver of the car, driver of the plane or driver of the train, or he is working in a factory with a moving object. Because if you tighten blood sugar, his blood sugar might drop one day and he might sustain an accident. Train driver, bus driver, if you try to control, he may not be aware that he is having hypoglycemia, he will sustain an accident. Not only his life will be at stake, the entire passenger's life will be at stake. So do not tighten blood sugar level. Those who are doing active works, particularly driving and moving vehicles, those who are having a sedentary life, you can. And again, food intake, at what type of food intake about sweets. One important point I want to highlight, do not ever try to put an absolute stop to sweet. That will have a disastrous consequences. I have seen even the doctors don't take sugars in the tea. No, I mean diabetes, I will not take sugar. See, in 1 cup of tea, how much sugar you add? 10 grams. What is 10 grams? 10,000 milligrams. We are having 5 liters of blood. I explained to many doctors that if I dissolve 10,000 milligram of blood glucose, that 10,000 is not in the glucose form, 50% is glucose and 50% is in fructose form. So basically we are taking 5,000 milligram. Now if I dissolve in 5 liters of blood, how much blood sugar is going to increase? Only 1 milligram. But for that reason, there is no valid scientific reason not to take sugar. Even for sweets, you can advise that you take sweets in moderation. Do not try to take rasgulla or good type of things. That will increase very high amount. And if you take a sweet, you can take definitely, but then on that date you take an extra dose of anti-diabetic drug, or there is a specific drug called acarbose or voglibose, you take that medicine. That will not allow glucose to be absorbed by the intestine. by decreasing sweet, by decreasing destroying one patient's psyche, to take sweets, you cannot prolong the life of the patient, neither complications. All the complications of diabetes are genetically determined. I repeat, despite aggressive control, complication does develop. Complications do develop because they are having a genetic propensity. So all the complications are not exclusively due to high blood sugar level, but a genetic element in it. So I'll have just a video, endless topic, diabetes. So in the Harrison book which we will be reading, Medicine is an ever-changing science. Yes, I conclude by saying that most illiterate person of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn and relearn. This is from Dr. B.M. Hegde, a very famous physician, cardiologist, and he was awarded Padma Bhushan and Padma Vibhushan. I have heard his lecture in the year 1998. Prolific speaker, cancer and insulin, B.M. Hegde. You see every word he is telling, I agree with it, but since I am a very low profile person, nobody will hear my statement. This is the identity who is speaking. See what he is speaking, every word is important.
This is important for our life, for earning bread and butter, to deceive people, that we understand a lot about whatever we are going to see. At least we have to pretend that we understand each and everything about it, looking at X-ray, so that your patient gets convinced that doctor knows a lot. To know that, you have to practice a lot how to read an X-ray. We had an introductory class, we had an introductory part of interpreting this upper limb X-ray, which mostly related to the bones we talked about. Now, the bones along with the soft tissues we just talked about in this particular upper limb radiology, along with this talking about the joints. So here in this radiology part of the thorax, we are going to introduce the organs or viscerals. Now the rule is simple. We have to make this particular thing simple so that we can just like have a quick understanding on the things, and we are not to go in a great detail of the radiological basis of anatomy. Simple thing in a way that we should be able to understand what kind of organ we are looking at, or what part of the body we are looking at, and what kind of like projections of the rays or the directions of the rays, how it is coming, and what exactly we are seeing and what exactly we are understanding looking at this structure. And if you understand something, there would be something which you cannot understand. If is there, we cannot understand that thing, we point out and we just like try to figure out if it is a normal or abnormal one. So once you know the normal, we can just like know the deviations from the normal, which is abnormal. So for us in this main one, we are just focusing on the normal sciagram or normal radiological anatomy. So first thing first, to begin with, the rules are there. Whenever you are given with the X-ray plate, or if you are looking at during examination or looking in front of your patient, whenever you are asked to just like tell about Dr. ki hoyeche bolun, what's wrong is going with this particular ei photo ta dekhun to ki dekha jacche, kar chobi kothakar chobi. So you have to interpret those things, and you have to just like narrate it to in a way to the patients, communicate as well to the patient in a way so that he can understand that little bit of whatever you are seeing and whatever things you are interpreting, so that he gets a convinced na lokta kichu ontto jane, amar theke ekটু বেশি জানে, ঠিক আছে, একে ভরসা করতে পারবো, আর একটু খানিকক্ষণ with patients I look into it. So whenever you are looking into sciagram plate in front of your patients, in front of your family members, or during examinations in front of us. So radiogram, if it is upper limb, lower limb, thorax, abdomen, if you are looking at, you have to specify the region. So most of the times in the thorax, which is a point of concern or point of the topic today, we are looking at the thorax X-ray. So we see that this particular thorax X-ray, the directions of this particular rays, to what direction is coming. So in the thorax X-ray, we get this particular views either coming from the front to back or back to front, or it is coming from the sideways, the rays, this X-rays, and it is making a projections to that particular board, as I mentioned, which is lying opposite to it and catching up the silhouette or the shadow of it, and looking at it and develop on it. So you have to figure out in order of reading an X-ray, first is if it is a plain X-ray or if you are looking something special or extraordinary. So what do you mean by this particular plain X-ray and a special X-ray? So looking at this particular skygram plate, if it is black, if it is white, or if it is gray, that means you are seeing an X-ray plate which is normal X-ray plate, which is nothing special about it. That means you are looking at the soft tissue shadows, which is not very clear. You are saying that this is a muscle or it's a soft tissue. That means it could be a muscle, it could have tendons, it have blood vessels, and in it together. You cannot precisely point it out, this is the blood vessel or this is the femoral artery I am looking at. So we cannot pinpoint it. We just like say it a general word, a soft tissue. That means it includes everything which is softer, and if it is other than soft tissues, that means it is a bony structures. If it is visible, any kind of bone if you are looking at, that's a bony structure. So soft tissue structure and the bony structure, likewise we mentioned about. If those things are visible, we call this particular X-ray plates as a plain or normal X-ray plate, right? So we do not see anything special on it. Now by any chance, if you are looking at an X-ray plate which is showing something which is normally can be seen, soft tissue shadows and this particular bony shadow, along with that, if you are seeing something like for example an artery which is having a tortuous course and blood vessels which is having a particular pattern, or any kind of organ like windpipe or any kinds of organ which is having a gross understanding that you can see the stomach, you can see the small intestine or a part of the large intestine or rectum, that means something special, you are seeing an extra. That means this is an extra spatial X-ray. So that particular word that has to come from your mouth or whenever you are writing it, it is a plain or a spatial. That's the first thing before you go for any further. It's a plain X-ray or it's a special thing. Special thing, that means it is happy birthday, seeing something more. I am getting more information. That's why we call them as spatial. Now after that, special means we had to add something special to make it special. That means this particular organ or blood vessels or a organ, it is not visible normally. We are making it visible by doing something special. But we are doing something, that means we are adding something. That means we are painting with something. Then it becomes visible. So we are painting some dyes, and then that dye, as it goes on it, sticks on that particular organ or runs through the blood vessels, then it becomes visible. Then we call them as, oh, we can see the blood vessel. And that particular dye or special element that we are introducing, we call them as contrast. It could be ions, it could be salt, which we are using that, which is maybe fluorescent in nature, which may have a particular pattern, which makes this particular organ visible. So this is in simple words, if you are seeing something ordinary or extraordinary, plain or special. Special means contrast, you are adding something special. Contrast means you are adding some radio opaque dyes, that means you are adding something which is making it fluorescent. Then view of the X-ray, that means whenever this particular X-ray image or this particular photograph is taken, what was the status of the patient, how the patient was standing or sitting or in a posture. In that posture, to which direction and through which way the rays are coming and to which direction it is leaving. That means if I call this particular X-ray as anterior posterior view, that means the ray is coming from the anterior side and it is penetrating my body through anterior to posteriorly and making an image which is catching on this particular board and making an impression or shadow on it. That particular shadow, if you are interpreting, you are seeing this particular organ anterior to posterior. We call them as, in short, AP view. That's the way. But in any ways, if that particular ray is coming from the back side and we are taking this particular plate in front of us, that means we call them as posterior anterior view. So we call them as PA view. That means the light is coming from that patient back side and it is reflected, or the shadow is reflected in front of us, which is making a silhouette or shadow, and which is catching, developed under negative film, and we are interpreting it. So that particular directions of this particular film we have to understand. So view of the X-ray, it is AP view or PA view, that's what. Or if the X-ray is catching the lateral sides from it. If it is coming from the right side and leaving to my body, penetrating it, going to the left side, or maybe it is coming from the left side and penetrating my body and going towards the right side. So, right or left lateral views, depending on. Now, whenever you are interpreting this right or left AP view or this particular lateral views over there, we usually give a mark on it, right, R or L, that helps us to identify what view we are looking at. Without looking at those particular marks, which is right or left looking at, we are just not going to mention which is the right lateral view or left lateral view. We just mention about this lateral view. So, these are the two views we talked about or familiar about, anterior posterior, posterior anterior view or lateral views. Right lateral, left lateral, doesn't matter. If it is mentioned, we are going to mention it is left lateral. If it is not mentioned on the left side, marking on it, we are not mentioning. We just like broadly saying this is lateral view X-ray showing this or this region, etc., etc. And the third view, in between anterior posterior and lateral, we have a midline thing, which is a vector which is running through 90 degree in between that 45 angle. We call them as oblique view. That means it's neither anterior posterior, neither it is lateral view. It is lying in between. You call them as oblique view. That particular oblique view also, it reveals some of the ideas or some of the areas which we are wanting to explore on. We will be seeing these particular three views in this particular region, and we will be understanding how these things look like and following the same principle. What principle? What region we are seeing here? What are this kind of X-ray we are looking at, the plane or spatial, and this particular region showing what? Bony shadows, soft tissue shadows, showing what and what you are exactly seeing. Now, in case of this particular spatial, bony shadow, soft tissue shadows, and something special if you are looking at. That's what you have to mention. So, these things are simple in a terms of looking at. There are two ways we want this particular views to be seen, anterior posterior or posterior anterior. In case of the thorax, most of the times we want to see these organs or this particular viscera that is present inside this particular thoracic cavity. We have the heart, we have the lungs present inside along with the coverings to it. And we have a limit which is limiting this particular lower margin of the thorax, which is diaphragm. So, these are the soft tissue shadows which you are seeing here, and this midline we have the heart tissue, along with that we have the space, we call them as mediastinal space. We also contain several organs like esophagus, trachea and lymph nodes, etc., etc. They are also there. So, we have a crowding of the organs or viscera in the thorax region. In that particular region, we also have covering over here, which is known as the ribs or thoracic cage. Now, this particular thoracic cage makes an impression on or over this organ or viscera. Now, if we want to bypass that, the image of this thoracic cage over these particular organs and viscera, which is present in here, we have tested with this anterior posterior view or posterior anterior view, both of these things. Now, whenever you are going to interpret the organs which is inside in our bodies or inside the thorax, we have seen the crowding of the ribs or the image of the ribs is less obvious if you take a PA view or posterior anterior view. So, in case of the thorax, we just like usually give you with this particular X-ray plates, which is PA view. That means we are focusing on the viscera organs which is present in the thorax. Now, that particular thing we are doing it to bypass the shadows which is laid by the rib cages. So, if the rib cage is crowding over here all this particular organ and viscera, the interpretations of the organ and viscera in the thoracic region is little bit difficult. Compared to that, if you just like take a PA view that projects more or less clear picture of the thoracic organs or the viscera. So, in case of the thorax, the views normally what you do here, we give that PA view or posterior anterior view. What do you mean by the posterior anterior view? Is that light is coming in front, light is coming from my back, like from the vertebral end, it is coming, and I am holding the plate in front of me. So, light is penetrating my back side first and then penetrating the organ, and that particular reflection is falling on the plate which I am holding like this, and that particular image is caught and we are developing that particular field. So, we call this as PA view. Now, when we do this AP view, we do the AP view if you are going to see these particular bones in particular, ribs in particular, thorax in particular, like in the sternum in particular. When do we do that? Whenever we have these particular patients coming with the trauma to the chest, we are suspecting there might be a rib fracture. We are not going to see these particular organs in detail. So we are going to see the ribs. So that knowledge you have to know. If you are going to see these particular ribs really very neat and clean, you have to make a view which is anterior-posterior view. And whenever you are going to see this particular organ in the thorax, we usually take the PA view. Am I clear with this particular concept or not? So let me just like clear this once again. In this particular region, whatever we are doing in this particular class or in this particular MBBS sessions, in the thorax region, in the view of X-ray, if you are looking at, is posterior anterior view. And whenever in a clinics, you are going to do this particular X-ray of the ribs, or if it is required to understand if it is a fractured rib or not, we do a AP view. But in this examination, during this particular anatomy examination radiology, we give this PA view of the thorax, right? So that's a rule. So let's move into this particular X-ray plate and see how it makes it out. So this is normally X-ray plate, which may be just like given on the view box, and you are interpreting that. So go by with the methods whatever we are planning with. So the first thing is what kind of view, what are the regions, what kind of X-ray plate you are looking at, those things you have to keep in mind in here. It's a general or it's a plane or special. Region, what you are seeing here. The view you are looking at. In case of the thorax, by default, you are looking at PA view thorax at this level. So go on, what you can understand. Talk to your friends or just like next to your, whoever sitting next to you, we can talk and just like figure out. It's a posterior anterior view. The view is posterior anterior view in the thorax region. PA view. In case of the thorax, X-ray thorax, it's PA view. That's a rule. By default, we are doing it. Okay, saying that, talk to your friends. Now let's do the drill. What kind of X-ray you are looking at? Plain or special? Plain or special? You don't see anything special in it? Nothing special about it? Ordinary guy? Nothing special. So if I call it a special, what could be the criteria to make it special or look it special? It should have some structure visible. What kind of structure? Which you are not seeing in normal ways. Artery, vein, bronchus, etc., etc. And you can really see that, right? So that's a not thing there. So it's nothing special about this particular plate. It's a plain X-ray. What kind of view we're looking at in the thorax region? By default, PA view. All right, it's a PA view thorax, which is a plain X-ray plate you are looking at. Now, one step ahead, what you are looking at. Now, describe it. What you are looking at. Showing what? Showing what? What you are seeing here. But step by step. Now, you can talk to your friends, then you can answer. All right? Showing what? Okay, now, showing what? Showing what? Now again, you have to go to the basic, as if nobody learns it, nobody knows it. Very basic. What you are seeing? Showing what? That's the thing which is already done. Showing what? এর মধ্যে কি কি দেখছি? কার কার ছবি দেখা যাচ্ছে? কে কে আছে? হলো না. Again fall back. You have to be systematic in approaching anything. You have to be disciplined, you have to be systematic, or else you will be going to miss it. Showing what? Follow the rules. Showing shadows of what? Organs. Showing shadows of organs, one entity. Next, second entity. Anything else? Showing shadows of organ 1. Okay, stop it. Then next point. And showing something else or not? All. Okay, thank God. All right. So plan. Showing shadows of soft tissue organs, as we are saying, right? Organs of the which region? Thoracic organs. Showing shadows of thoracic organ, right? Then stop. Then and showing shadows of bones. Which bones? Thoracic bones. All right, now you go on describing it. Thoracic bones like? All right, now you are in track. Now you wait. Now again talk to your friend. Again you have to be systematic whenever you are talking at it. You have to be a disciplined manner. We are going to be আপনাকে একটা ওষুধ দিলাম আবার খানিকক্ষণ করে দিলাম না ওষুধটা কাটলাম আবার বললাম. You cannot do that. We have to be disciplined so that people understand we are organized. You have to be organized in presenting it. Like sternum. Okay, sternum, ribs, clavicle, scapula. Anything else? Okay. Now, shadows of bones, whatever you're seeing here, ribs, clavicle, scapula, anything else? Sternum, vertebrae. Good. Majority of the bones is covered. If you see anything else, you have to mention it. If not, if you're seeing a whole bone, you have to mention that whole bone. If you're seeing the part of it, you have to mention part of it. Clear? So, then, anything else? Anything else? No, don't go into soft tissue yet. Still we are in the bone. We are still on the bone and we have to finish something else in regard to the bone. Then we can move into it. Joints. All right. Joints. Then what are the joints we are looking at? Okay. Now you are in a track. Now you are covering the points. Now you are not missing anything. So you have to check everything. Whenever you are interpreting it, you have to check everything. Because people are paying you to check it. Because they cannot read that. আমি যদি একটা ছবি এসে বলি যে দেখুন তো কে কে আছে এই আছে এই আছে এই আছে এই আছে কিন্তু এই ইন্টারপ্রিটেশনটা তোমার কাছেই আসবে and you will be paid for it to interpret it. So your interpretations has to be in a logical sequential manner so that you do not miss anything and you have to make it a habit. If you're seeing bones, you have to see bones. If you're seeing a whole bone or part of bone, if you're seeing whole or part of bone, that thing is done. You have to see that if that bone is contributing in a joint which is visible or not. If you're seeing the joint there, it's a whole joint you are seeing it or it's a partial joint you are seeing it. If that particular joint, then you have to see that these particular bones are healthy, no fracture line, joints good, no effusions or nothing wrong with this, no dislocation, etc., etc. That's a pathological thing. So once you do this normal thing, then you can go for the abnormal things. Right? So then everything covered in the bone shadow. Then you move to the soft tissue shadows. Next part. Soft tissue shadows showing what? No. Now you talk to your friends. Then you make it your mind. Then you come to me. Okay, all right. Now soft tissue shadow off. Again lungs, then you break it down. Lungs, 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 lungs is not done yet. Lungs, you are not done yet with the lungs. Right lung, left lung visible, left lung, right lung, left lung. So shadows of right lung and left lung. Slung. Now, what are you seeing in the lung shadows? All right, so one right side or left side? Which side you are going to describe? Which lung you are going to describe? Left side. Okay, left side. Left lung showing cardiac notch. Cardiac notch. What else? What else you are seeing in the cardiac shadows? How diaphragm is coming on the lung? Border. What border you are seeing on lung? What border you are seeing in? কি কি বর্ডার দেখা যাচ্ছে এই এক্সরেতে? কি কি বর্ডার আছে লাংসের যেটা এখানে দেখা যাচ্ছে? সব বর্ডার কি দেখা যাচ্ছে লাংসের? যদি না যায় কোন বর্ডার দেখতে পাই? How many borders lung has in a viscera? 3 borders. এখানে কি কি বর্ডার দেখা যাচ্ছে? আপনার তো বর্ডার টর্ডার গুলো খুব খারাপ হয়ে গেছে, আর ভালো বর্ডার করে নিয়ে আসুন। বর্ডার দেখা যাচ্ছে? Do you see any lung border or not? Inferior border. This is inferior border. Oh, this is inferior border. So inferior border. You are seeing now inferior border. So this is anterior border. So this has to be the anterior side, right? Now in case of this X-ray, এই বর্ডারটাকে আমরা বলি mediastinal, কারণ কি এই mediastinal স্পেসটা MSK অকুপাই করে আছে। mediastinal সারফেসে থাকে এই mediastinal lung you are seeing in addition to it, আর কিছু নাই। লাংসের চ্যাপ্টার শেষ, all done, আপনার লাংস পড়া হয়ে গেছে, আর কিছু নেই লাংসের। Apex of the lung, it looks like easy peasy, but if you break it down, look at it, it's informative, and it is really informative. So you are seeing the apex of the lung. Diaphragm borderটাই base of the lung, তার মানে কি সারফেসও দেখতে পাচ্ছি, not only the border, it corresponds with this base of the lung, which is basically inferior border, which also present the mediastinal surface as well. Any surface you are looking at? See, you are not done with the lung yet. Surfaces you are looking at. বলতে হবে, বলে যেতে হবে। So, thing is that this is the way we are interpreting. Left lung. আর কিছু দেখছো? Additional কিছু দেখছো right lung এ? Whichever you have mentioned, anything additional on the right lung you are seeing, which it has the same silhouette or it has something extra or something less informative? It has less. গোলাটে দেখছো ঘেটে গেছে একটু, mediastinal সারফেসটা অতটা ভালো নয়, অতটা ক্লিয়ার কাট নয়, right? Because of prominent. Anyways, other than this, anything you can make it out of this? হবে কি করে বাবা? লাংসের কাভারিংটা কি? Pleura. Okay, pleura. The covering of the lung is pleura, right? Which you have to regard to this particular lung and this particular pleural shadow. Can you mention? One space আছে related to the lung, which is related to the inferior margin of the lung. Now identify that particular space. So you didn't mention that. I mentioned it. And this brings money. See, if you have a disease where you cannot see this angle, not visible, so you have to know that particular angle, which is costo-mediastinal angle, costo-diaphragmatic angle. So these two angles matters a lot. So this is how we interpreted this particular lungs, right? Now next to lung, what else we can move in the, what else you are seeing here? Heart. Okay, now again, কি দেখতে পাচ্ছ? What in a heart you are looking at? তুমি তোমাদের বন্ধুদের মধ্যে কথা বলে নাও, দেখে বলো যে কি কি দেখতে পাচ্ছ, ভালো করে দেখে নিয়ে বলো। So shadows of the heart you are looking at. So what you are seeing in the heart? Chambers দেখা যাচ্ছে হার্টের? দেখা যাচ্ছে না? ওকে, হার্ট কি দেখা যাচ্ছে? লেফট ভেন্ট্রিকেলে দেখতে পেয়েছি। আচ্ছা বেশ, আর কি দেখতে পেয়েছো? কর্ডি টেন্ডনি। So looking at arch of aorta, কোনটা? তাহলে হার্টে কি কি দেখা যাচ্ছে? ওই দেখা যাচ্ছে, ওই দেখা যাচ্ছে করে বললে হবে না। Again you have to be disciplined and systematic. আয় দেখো বর্ডারস গুলো দেখতে পাচ্ছ, রাইট বর্ডার অফ দ্য হার্ট, লেফট বর্ডার অফ দ্য হার্ট দেখা যাচ্ছে। লেফট ভালো দেখা যাচ্ছে, রাইট অতটা ভালো দেখা যাচ্ছে না। রাইট বর্ডার, লেফট বর্ডার দেখা যাচ্ছে। রাইট বর্ডার, লেফট বর্ডারটা খুব ভালো দেখা যাচ্ছে, you can see pretty well the left border, right border, right? Along with that somebody sees arch of aorta দেখতে পেয়েছি, right? Those things is visible. এরকম করে দেখিয়ে বলেছো। না না ও বলেনি, আমি বলছি কেউ বলেছে। So let's make it out with this particular thing. See that. This is how we are going to see that. That's not going to be or through and through penetrated by the X-ray. Whereas this particular shadow over here in the heart is not that visible. Now you just make it out the lines which is following this particular different colors used on the heart shadows. And this is indicating the borders of the heart. So you can make it out which border you are looking at with different colors placed on it. So red line is there down which is reinforced by the blue line. So what borders on the heart you are seeing here? What's the red border? Left border of the left line, red line touch left border of the heart. Right side? Arch of aorta. আমরা কি বলি? AK. It looks like a knuckle. So we call them as aortic knuckle. So this is what we are seeing here. Most of the time put a pointer here and there and there and there. We ask you to identify seeing it. Just interpret it. So this is what you are seeing here. Aortic knuckle, that's what you can see. And once you can figure out this particular thing, then you can see some other organ which is limiting the lower course or lower limit of the thorax, which is the diaphragm. Now the diaphragm have three components, central part and peripheral parts. Peripheral parts you call them as domes of the diaphragm. They are right dome and left dome. You have to measure what? Whether they are lying at the same level or if they are in a different level. If it is there, which one is a higher level, which one is low. If that is normal or not normal, that you know anatomically. And then you have to figure out this particular under the diaphragm we have some shadows or not. So we call this under the diaphragm FGS, fundus gas shadow, which is related to the stomach, which is the fundus region of the stomach holding the gas there. So this particular interpretations also comes along with that. So these are the basic which is easy to find it out regard to this particular cardiac shadows, regard to the lung shadows, regard to the diaphragm which you see in here. The level of the diaphragm we ask you about the domes of the diaphragm, whether they are on the same plane or not. If they are on the same plane, why they are on the same plane? If they are on a higher or lower plane, why they are on a higher or lower plane? What's the normal thing about that? Now, what normally this particular thing is visible, and apart from that we just like have to follow a midline shadows in this thorax region, which is lying a little bit on the higher plane or in the thoracic or thoracocervical region, which is a midline shadow which represents this particular region. You see the black shadow which is coming over here. So this particular midline shadow, black shadows which you're seeing here, a little bit very obscure, not that very visible like lungs or these hearts and everything. We call them as TS or tracheal shadows. So normally the normal positions of the trachea, we can see that this particular trachea is lying here, right? This is a trachea. So this is how we see that trachea, feel the trachea. If you look at it, you put the finger like this and you see that this particular trachea is little bit not in the exact midline. It is shifted to some side. It has a reason why it is shifted to it. So we call them as normal positions of trachea, how to figure it out. In the physiology, they will teach you how to figure this particular trachea, what's the normal position and why this particular normal position is there, just like the diaphragm positions. And if you have an abnormal positions of the trachea, what could be the consequences, etc., etc. So this is how we interpret this particular cardiac shadow or thorax region shadows. So this particular regions we interpret this particular lung shadows, interpret this particular Cardiac shadows, we mostly figure on or look into this particular borders. In case of the lungs, we also look into this particular upper pole of the lung. We call them as like apex of the lung, which is very much visible and very much important for us. We understand this particular lower limit along with this particular pleural extensions, which is down there. We call them as recess, which is the empty space between the pleura, lower margin of pleura and lower margin of the lung. And this particular region have two of them, costodiaphragmatic and costomediastinal. Out of that, we have to know the theory behind, like which one is lying in the lower level and why this particular lower level thing is there, what accumulates there if something accumulates in it, etc., etc. So these are the normal thing which is expected out of here in this region. Along with that, you can see the bony shadows. Now, regard to the bony shadows, what you can be tested with, if you are looking at the ribs, you have to just like say that ribs, what you are looking at. Now, thing is that whenever you are interpreting this particular ribs in this particular thoracic region, assuming this is what view you are looking at? PA view, that means posterior anterior view. This particular PA view, whenever you are interpreting, this particular interpretations of the rib will be front to back. Will be just like a tracking this particular X-ray plates or ribs. If you are counting the ribs, you will have count this particular rib which is from the head end. That means you have to count in this region, you are seeing this back side of the ribs. And this is the front side of the ribs. This impression is the rib 1. This is the rib 1. So we interpret the rib counting is coming from front to back like this. Like this. This is how we count the ribs, not like this is 1, 2, 3 like that. So this rib counting, you will be learning that in the clinics whenever you are going to count this particular ribs in a patient in a given skygram or radiology session. In the mid 5, like whenever you are going to for the approaching for the final, you will be doing this particular rib counting, how to interpret. So I am just like saying that this particular ribs, you have to count this particular ribs from this end to this end. This end, what you are looking at, this is the vertebral end. So this particular region, we have to count it like this. So this is the way we interpret, count the ribs from here. But anyways, taking it from here, we like see these organ visceral impressions, lung shadows, cardiac shadows, diaphragmatic shadows and tracheal shadows if possible in this particular regions. So this is the normal thing regard to this particular thorax X-ray and thorax understanding on these regions. Now talking about the mediastinum. This particular mediastinum, you see that this midline space which is lying in between them. If you see that, look at this particular mediastinum, which is normal mediastinum, it looks like that. It is a narrow scanty space where this particular heart is there. And this region is not occupied there by anything other than great vessels. So we have this particular arch of aorta, we have these pulmonary arteries which is placed in here. So this particular region, if you have this lymph nodes, soft tissue shadow, esophagus, trachea coming over here, we can just like see this particular region as mediastinal shadows. So this region is the midline mediastinum, and you can see that compare with this previous one, this particular region of the mediastinum is wide. This is kind of like abnormal region which you are seeing here. We call them as mediastinal shadow, which is widened mediastinum. But again, we do not ask you about mediastinal shadows in the undergraduate classes. Now this particular view you are looking at, you have to just look into the views. It's not that PA view we are looking at, it's something different. What view you are looking at? Is this lateral view, PA view or oblique view? So it's an oblique view, it's not an AP view, neither it's a complete lateral view. How the lateral view would be looking like? This is lateral view. So you are seeing this particular individual from the sides. This is the vertebral end, this is the sternum end. This is the cardiac shadows which is present in here, and this is the lung shadows which is making an impression with this particular bronchus or bronchial vessels which is going there. So this is a lateral view X-ray which is limiting here is the diaphragm. You can see the lower limit where the diaphragm is. This is the apex of the lung, this is the bottom or base of the lung. This is how we interpret, and the bones which you are seeing here which is present. This is anterior posterior is denoted by the bones which is present. Now this one is not anterior posterior, you are seeing something else, like you are looking at this particular individual, this is the vertebra you can see, and this particular projections which is occupying this particular bones which is lying over here. What bone is lying here? The shadow of scapula. So you are seeing the scapula in addition to it. So you are seeing something individual from the oblique side or 45 degree angles. So this particular view is the oblique view of the thorax region. The same thing, showing soft tissue shadows, showing bony shadows, etc., etc. Bony shadow, that means bones plus joints if you are seeing any, and if the soft tissue shadows, what are the organs you are looking at, and what are the extremes of the organs you are seeing here? Diaphragm, or this particular apex of the lung, trachea, which you can see here going down up to the here and then splitting here. So this is how we interpret the thoracic X-rays in examination or during examination. Now this is an abnormal picture. That's what I am showing here to understand what's the difference of knowing this particular normal anatomy. So in this particular picture, which organ do you think is not behaving normal? Lungs, heart, diaphragm, and anything else. Lungs. Which lungs you have to figure out, right lung or left lung? So left lung it's not working. So what you are missing out here is that looks like it is falling short, like this is short, like lower lobe of the lung is not present in here. Along with that, what we can see there, this region we call them as angle. What angle? Visible here. What angle we call it here? Visible here. We call them as loss of angles. When it happens, something accumulates in this pleural space. What can accumulate in the pleural space? Fluid it can accumulate. It can accumulate blood, including fluid. It can have a pus. So that particular obliterations of these things, which is known as thorax. If it is pus, we call them as pyothorax. If it is water or clear fluid, we call them a hydrothorax, etc., etc. Right? So this is how we interpret with these normal and abnormal things. Now, this is what we are seeing here is the abnormal thing. Same on the left side it is there. But here you see that there is a clear cut level is there. Compared to the previous one, you see that this is a little bit like do not have a clear cut straight line. Here you see that this particular lungs ending in something like an irregular margin, whereas you see that this particular lungs is ending on really sharp margin. You can see the same thing, cannot see this particular angle seen here, obliterations of the angle, but this particular lung is ending on the straight line. This particular interpretation is accumulations of the water and as well as accumulation of the air or air something else as well, which is leading to the collapse of the lung. We call them as hydropneumothorax. We have the air which is limiting here, we have the water, and it is a line which is making here, which is straight line. So this is kind of like an abnormal thing. Now this is what you are seeing here, the cardiac shadows. This cardiac shadow is looking like normal or abnormal. Looks like this particular heart looks like a water bottle. We call them a bottle shaped heart. You see that this particular dimensions of the heart from here to here. That means the blue, this yellow line and the black line total dimensions. And this particular C line, which is denoted by the red, which is the entire dimensions of the thorax. You see that this particular A to B or this line to this line, A and B together is making a big line compared to this particular C1. So this particular thing we call them as cardiomegaly, which we interpret in a way. But again, this is for your understanding how you interpret the diseases, etc., etc. Now coming to this particular special thing, what makes something special? If we can see some bronchus, if we can see the bronchioles, if you can see the arch of aorta really well, the cavity of it, if you can see these coronary arteries in this particular X-rays, that makes this particular X-ray real special. Just like what? Like this one. You are seeing this bronchioles which is breaking down, bronchus breaking down in the bronchioles, and this particular respiratory tree is visible, this side and this side. So you can see that this is a kind of bronchus, right principal bronchus, upper lobar bronchus, middle lobar bronchus, lower lobar bronchus. Then it is splitting down into segmental bronchus, etc., etc. So you can see the bronchus interior to it and how it is going inside. This is not visible in a normal X-ray. That means this is a special X-ray. We call them as bronchogram. What makes this special? We put some dye here. Said that particular dye sticking to this particular walls, and when it sticks to the wall, we take the picture and then we analyze it. We call them as bronchogram. Similar to it, you see this aorta or arch of aorta. This is normal arch of aorta. Normally, you can see that knuckle, that bulge here. Here you can see that this part, we call them as ascending aorta. This is arch of aorta. This is descending thoracic aorta. Everything visible. This is intrigue and detail you are looking at. So this is a special X-ray which is showing normal shadows along with something special. We call them as arteriogram or aortogram. Something like this. We are seeing the coronary blood vessels, the coronary, right coronary artery, left coronary artery. They are visible and you can see the branching of them like marginal artery, etc., etc., ventricular branch, etc. They are coming out. Normally not visible. We are again giving some dyes taking the picture at that particular point when this particular dyes reaches to that particular point, and then analyzing it. So we are analyzing microstructures which is present on this and not visible normally. We call them as X-ray, which is a special kind of X-ray. Make sense? Now this is how we are seeing here. Now with this particular special X-ray, what